Hi, this is Terry Kuti, founder and director of DeepC Foundation. I'm joined today by my guest, Dr. Minas Chrysopoulou, who is from PRMA in San Antonio, Texas. Dr. Chrysopoulou is a board-certified, specially trained in microsurgery for breast reconstruction patients, specializing in all kinds of flap surgeries, in particular DIEP flap. They have done thousands there. I looked at your statistics the other day. It's mind-blowing. You've done thousands of successful flaps there. But Dr. C is also the founder and developer of the Breast Advocate app, which is a free shared decision-making app for those affected by breast cancer. And you can find more information at breastadvocateapp.com. Welcome to the program, Dr. C.
Great to be here. Good to see you.
Good to see you too. I feel like these videos I have been doing recently are a little bit of a time capsule because we're doing them during the pandemic. And honestly, as we are filming this, there is a convention that we normally both attend and do side-by-side videos at, but it's virtual this year, and here we are in the pandemic. So I hope that, we can do these another way soon, but this is working out great. So thanks for stepping up to the plate again.
Anytime. What are we talking about today?
Well, so today, what I'd like to talk about is reducing abdominal complications. I have a number of women who talk to me about hernias, bulging, loss of function in their abdominal area. This is really specific to autologous reconstruction and DIEP flap. So,
well, you know how I feel about the belly.
Yes, and we have done another video on that. So let's roll again and let's talk about minimizing complications to the
So hernia and bulging, thankfully, are pretty uncommon with DIEP flap surgery. You're looking at about a 3% risk of a bulge. A bulge is basically everything is intact, but the tissues get a little bit loose, a bit lax, right? So you get a little pooch. Women who have had multiple pregnancies, previous abdominal surgery, they're at increased risk of abdominal complications like a bulge or a hernia. A hernia is 1% risk, and that is when the strength layer on the inside of the belly, under your skin, on top of the muscles, that gives way. So everything under that bulges out. So that's when you get a hernia. A hernia is a hole in the fascia. The fascia is the strength layer. So anything that, lots of cuts in the fascia, that increases the risk. Removing muscle increases the risk. Cutting a bunch of nerves that power the muscle so that it maintains its tone, that increases the risk of a bulge. Really, those three things are really key contributors to abdominal complications like bulging and hernia. Of course, there are other types of abdominal complications like wound healing issues. That's probably the number one complication in terms of frequency. Thankfully, again, it's low, but it's higher in ladies who have a higher BMI, diabetic patients, especially if they're not very well controlled in terms of their blood sugars, smokers. Smoking is a no-no. So all those things contribute to complications, the risk of complications. And the other thing that women need to know about is the number of previous belly surgeries that you've had increases your risk. So if you've had, so again, anything that has cut that fascia, that layer before, the more times it's been cut, the higher the risk of a problem with it after DIEP flap surgery. So if you've had multiple C-sections, a hernia repair and a hysterectomy, abdominal hysterectomy, if you've had all those, you are at higher risk than someone who's never had abdominal surgery or who's had only one C-section or something. So it's a spectrum. It's a spectrum.
So that was a good explanation. So here to me would be the question for patients when they go in for a consult. First of all, full disclosure on all their surgeries, which they have to have in their medical records. But the fact that you talked to us about the weakening of that, the more it's cut, that made a lot of sense to me. So now, some of this, I think some of the onus is on the surgeon.
Oh, for sure.
How often do they deal? I'm talking to these patients out here that are in their consult. How often does your surgeon deal with this? What kind of success rate is there? What do they do? Because here's another term that you use, Dr. C, that I don't know if a lot of patients know about. It's the motor nerve. Because you have to cut nerves when you have any kind of surgery, most surgeries. And that motor nerve, well, you talk about it.
So, okay. Do you know anyone who's paralyzed?
Yes, I do.
So they're in a wheelchair all the time? Correct.
They are paraplegic from the waist down.
Okay. So someone who's paraplegic, the muscles in their legs have wasted away, right? So there's no muscle bulk or tone.
Right.
The muscle is still there, but because they're paralyzed, the motor nerves that were feeding it and powering it and getting it to move and function and twitch and contract and move the leg, that has been removed because of the spinal injury. So what happens is the muscle just wastes away, atrophies. So you go from a big bulky muscle to just these tiny wispy fibers that do nothing, essentially. So the same thing can happen to your rectus muscles, your rectus abdominis muscles, your sit-up muscles. If the DIEP flap surgeon goes in, and since it's a DIEP flap, they're preserving all the muscle. But if they're not paying attention to the nerves that are coming into the muscle to feed it, the side, and they're just cutting it through, they'll grow back or whatever, that's not good. So you can save all the muscle and say you've done a DIEP flap, but unless you save the nerves that are powering it, you're not doing the patient any favors. So there are things that we do as surgeons to prevent that. So number one, you look out for the nerves and you preserve them. If a nerve has to be cut, let's say you've got 2 blood vessels and a nerve passing between the two, and you need both blood vessels, and you have to cut that nerve because you can't do without both blood vessels. You absolutely need both blood vessels to get the best blood flow. Well, then you cut the nerve and then you should repair it. So not all of us do that, and not all of us feel so strongly about it. I'm expressing our opinion in our practice at PRMA. So anything you can do to preserve muscle and the nerves, that's what you got to do. Sometimes the blood vessels that you need, because ideally the whole piece of tissue, the whole flap, only needs one blood vessel, one perforator, right? So the blood vessels that feed the skin and the fat that we take with a DIEP flap, they're called perforators because they perforate through the muscle. So we go into the muscle. You don't cut the muscle out. You go into it, you spread the fibers, and you pluck the blood vessel out between the fibers. Sometimes you need more than one perforator to get the best blood flow to that tissue. If you don't have great blood flow, then it can turn hard and you get a lot of fat necrosis, which we've talked about before. So if the blood vessels are in line, the muscle fibers, if you imagine, your head's up here, your feet are down there, your muscles travel up and down your body, your six pack. So the fibers are arranged head to toe.
Right.
If you've got two blood vessels and they're traveling between the same fibers, you can take both those blood vessels without cutting muscle. If you've got one blood vessel that comes out here and another blood vessel that comes out here, you've got to cut all that muscle in between, right? To get both blood vessels that you need. And as you know, we use things like the SPY during the surgery. So in that situation, if I'm thinking, that single perforator it doesn't look very big. I think I may need this other one over here, but that's a long way away. And look at all the muscle in between. You know what? I'm going to put a little clamp on what I think is the smaller blood vessel. And then I'm going to bring in the SPY to check the blood flow just on that one blood vessel, because then I can just use a single perforator. I don't have to cut any muscle. I don't have to cut any nerves. A single perforator flap. Well, then we bring in the SPY, we shoot the dye, and we look at the flap, and you know what? A third of it has no blood flow. And then I take the clamp off that other blood vessel, that second one, and now all of a sudden, the whole flap lights up. So now I need all the tissue.
Yeah.
So I need both blood vessels, right? So what a lot of DIEP flap surgeons do is they'll cut the muscle. But if you're cutting more than a centimeter or so, especially if it's a narrow muscle, because some people's muscles are this wide, other people's muscles are this wide. It's a personal thing, right? It's an individual thing.
Oh, absolutely.
So if you cut a ton of muscle, you may as well be removing it. So now, strictly speaking, cutting that muscle in the example I just gave you, as long as I maintain some muscle fibers, just cutting it, that's still a DIEP flap because I didn't take any muscle with the flap.
Right.
Okay.
Still intact.
It's still there. It's just been cut. And so if you cut a muscle, it springs apart. It doesn't grow back. So if you've only saved a little strip of muscle on the side, and that's the only thing the patient has left, again, you haven't done them any favors. Yes, you've done a DIEP flap, but you've cut 3/4 of their muscle, right? So, and I know we've talked about this before, that's where the apex flap comes in, right? And so what's the apex flap? The apex flap is a type of DIEP flap. What it does is, in that situation where you've got, let me draw something here.
Go right ahead. This is fascinating stuff because loss of function, hernias, and bulging are words that patients are using. And so I think it's really important that they're hearing this information. So hopefully they can play this back, truly understand it, talk to their surgeon, and say to them, hey, how do you preserve that motor nerve? I always think of the motor nerve as kind of a communication, it talks to the nerve to tell it how to function. If it's cut and not repaired, then there is the loss of function. So that's in my layman's terms, in my patient terms, that's how I think of it. So
look at this example. So you've got, actually, let me color it in a little bit more.
Is this from Art 101 in med school, Dr. C?
Yeah.
I have to tell you, you're doing a bang up job.
Oh, well, thanks.
Oh,
so
nice.
So this is the rectus muscle, right? The muscle fibers going up and down.
Right.
And you've got two blood vessels, one perforator here, one perforator here. But as you can see, and then I've drawn the way that they connect to this big blood vessel here. This big blood vessel, we're going to cut it here, and this is what gets connected in the chest. Okay? But for me to get this and this, it would mean that I would have to cut all this muscle, because this is looping under the muscle and this is looping over here. So what an apex flap is we save all the muscle, but what we do is we go under the muscle here and we cut this blood vessel here. And then we go under the muscle here and cut this blood vessel here. And then we bring them both out and we connect them on top of the muscle. We reconnect. So, and that's what an apex flap is. So basically it's replumbing, but excluding the muscle. So instead of cutting it, we're pulling away from the muscle and then reattaching. The problem is you don't know, as I mentioned before, we bring in the spine, preoperatively, we get CT angiograms sometimes. We don't get them on absolutely everyone. Some practices do. That's their preference. That's cool. That's fine.
Right.
That's a style point. We tend to limit things to when we have a specific questions. If someone's had previous surgery and we're not sure about the perforators, then we'll get it, but we don't get it on absolutely everyone. But even with a CT angiogram, you don't know, without the SPY, you don't know that you need both perforators. So you need the SPY. In our practice anyway, the way we do it, we have to test the blood flow that the patient has with their anatomy using the SPY at the time of surgery, before we know whether someone needs this extra work or not.
And when you reconnect that plumbing with the apex flap, are you doing it right there at the belly before you transfer the flap?
Yeah, that's my preference.
Yeah.
You can do it both. You can do it up in the chest too. But yeah, that's how we do it.
The way you described it, I'm just thinking it makes more sense to do it right there.
Yeah, no, it does. In terms of the flow and stuff for us, that's the way. Everyone's doing different things, and so that just works out better that way. And then that extra work is done on the belly before you transfer it, and it kind of that's one less thing after you move it up, right? So. The apex, there was a good article about the apex, the terminology, many of us, we've been doing it for many years at PRMA. Many microsurgeons have been doing this. The good thing about the term now is that there's terminology so that everyone knows what we're talking about. right?
Yeah.
So having the vocabulary now, it really helps. Whenever there's something that's new, though, in terms of description and publications and all the rest of it, anyone reading this now thinks, well, I don't want a DIEP flap, I want an apex flap. It's like, well, strictly speaking, you're not actually going to know if you need one until the surgery. You've just got to make sure your surgeon knows how to do it if you need it.
Okay,
But,
that right there is good vocabulary.
right? So, ask your surgeon, doc, if you need 2 perforators, do you cut the muscle or do you do an apex flap?
Mm-hmm.
When would you do an apex flap? If you have to cut the nerves or a nerve, do you repair it? When would you repair it? Why wouldn't you repair it? These are the sorts of the nuances. So, if you have a surgeon that can have this conversation, then you're going to be just fine, because if you need it, you'll get it. But, it's all about, this better than anyone. It's all about knowing what questions to ask.
So that's why we love having you on the program and these other surgeons, because when you do successful flap surgeries or any type of reconstruction, listening to your processes, listening to your successful surgeries, these are the questions they should be asking. Take the time to listen to these videos. I always say I want them to feel like if I wasn't sitting here, it should be them listening to you, so they know what questions to ask when they go to their surgeon. Because let's face it, I taught school for a number of years. Not all teachers taught the same way. We based it off the same curriculum, but we taught differently. Same way with microsurgeons. You got to ask the question.
Yeah.
So I mean,
and also I think people need to remember that most surgeons aren't going to expect this level of conversation.
I want to change that.
Yeah, and you're doing a phenomenal job moving the dial. Mm-hmm. But what I'm saying is, just, if your surgeon reacts a bit weirdly, it doesn't mean that they don't want to have the conversation. They may just be taken aback a little bit by your questioning, if this is the level of questioning you're going to have during your consult. So don't automatically presume they don't want to have the conversation just because they're surprised with these questions.
And I would throw this out here to Dr. C. For those people that are listening to these videos, listen carefully. Don't just throw a term out to a doctor either if you don't truly understand what you're talking about. That you can bring something up, you can bring a term up. If you don't really understand what you're asking, you're not going to understand the answer when they give it to you. You see what I'm saying? So,
yeah, don't ask the question just for the sake of asking it. I mean, you've got to try and understand it yourself.
Yes,
you've got to know what you're asking.
Yes, but I do encourage the viewers to ask the question about, reducing abdominal complications. I think that is probably.
Yeah, I mean, that's the best place to start.
Yeah, I mean, we can sit here and they can throw things out like motor nerve, donor site morbidity, bulging her. Ask this question: how do you reduce any abdominal complications during DIEP flap?
Yeah, and then also, doc, what can I do to decrease my risk?
Yes.
Okay, so
compliance.
BMI is important. Getting yourself tuned up in terms of, if you're a diabetic, if you have diabetes, take that seriously. So it's so common these days. People just don't, oh yeah, my sugar, no, that's what's going to land you in trouble. Okay. So if going in and asking about an apex flap when you're not taking care of your blood sugars, it's missing the forest for the trees, If you're going to sneak a smoke here and there, so this is a team event.
It is so much. And people they ask me, they go, well, did you have wound complications? Did you have, I think I was a good healer, but I tell them too, even through all my middle child orneriness, I was a very compliant patient.
Yeah. Unfortunately, that isn't always enough, right? There's the risk of complications is always there, right? Unfortunately, that's the nature of the beast.
It is.
That's something else that people need to understand. And just because your surgeon, just because you may develop a wound healing complication doesn't mean your surgeon did anything wrong.
Or that
it doesn't mean, exactly, that's what I was going to say. It doesn't mean that you did anything wrong.
Yeah.
You can be the most compliant patient on the face of the planet. You can tune up your nutrition. You can be OCD about your nutrition, working out ahead of time, being fit before you go into surgery, never had a cigarette in your life, no drugs. You can do all that stuff and you can still develop a problem, unfortunately.
That's the risk of surgery. So
Yep. Yeah.
Great information today. Great information. So if anyone has any questions about this video on reducing abdominal complications, please watch it. If you have questions or comments, place it in the comment section. If I can't answer it, I'm going to, let's see, which direction? This guy. And we'll find out what the answer is. So thanks for watching. Thank you, Dr. C, for joining us again today. Stay safe and appreciate your time.
Take care, Terry.
All right.